So now it's my proud privilege to invite Professor Mahmood Ayyaz on a very important topic, and that is QI project in residency program. Professor Mahmood Ayyaz is our mentor and teacher, and he is a man who has delivered at all levels, right from National Residency Program of CPSP as a Principal Services Institute of Medical Sciences, and as a National Course Director on various live sport programs. So may I invite Professor Mahmood Ayyaz?
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. First of all, let me congratulate Khadija and Irfan for this brilliant effort and whole of the team. So पहली दोनों आपकी presentations जो थी, they were recorded and online presentations. So let's have this fun of having a meeting face to face. So I'm going to talk about this topic of implementation of quality improvement and safety programs in the residency programs. Why they're important and how do we actually do it, we'll speak from that forum. Actually, I was taking notes from these two great talks by Professor Khalid Haq and Professor Roger Saul, and they were great lectures, really worthwhile listening to. And they actually gave us a wealth of wisdom and a lot of knowledge and a deep insight into the quality improvement programs. And that is what we intend to do in the residency programs as well, because these have to be inbuilt. They have to be inbuilt in the residency program so that people should learn what are quality improvement targets and what are safety procedures right from their residencies. So first of all, I have a picture to show you. Can you recognize this professional? Okay, I'll make it easy for you. He's a cliff jumper, a professional cliff jumper. He would actually come out every other day, come to the edge of this cliff, assess this fall of 275 feet down into the deep ocean, assess that how much thirst he has to make to avoid this little ridge down there. Otherwise, he's going to strike it and get himself killed. Would assess the direction of the wind, would not like to jump against the wind because he's going to hit the rocks. Would know that how much is the depth of the water there, and would know, are there rocks or any animals down there who can hurt him? And after this, he is going to make this leap. He's going to thrust forward. He's going to actually leap in the air, make an angle of his body so that his body hits the surface of water in such a way that he does not have a great impact. Who would actually then swim out and perform the same procedure day in and out for years and years to come. Imagine, so he is actually living and surviving on his own survival skills. He's got a special set of skills to survive. Imagine you're a healthcare provider, a resident, who every day would come to the hospital, jump into his training practical grounds, do all the work, the difficult work, do it successfully, and then come out of this hospital every day, day in and out, for weeks, months, and years. Because you as a resident or a healthcare provider possess a certain specific set of skills which help you survive in this hostile environment of the hospitals, most of the times. Take the other end, your patients. They do not possess a certain specific set of skills. They do not know about the hospitals. They're unfamiliar with the hospitals, the working of the hospitals. And in the process, when they come down every day into the hospital, there is a possibility that they might just get lost into the hospital environment, may go and see a wrong physician or consultant, जिनकी उनको जरूरत नहीं थी, get a wrong set of investigations done, wrong treatment, and sometimes even wrong surgeries. And this might leave them emotionally and physically hurt sometimes. And sometimes they can die. So that is the other spectrum. I want you to think about that. We'll take you to another picture. Here you can see an expert and a master trapeze artist hanging upside down on a rope. He's learned his skill, he knows the environment. And you can see this little girl just leaping in faith, hoping that this trapeze artist, this master trapeze artist, is going to hold her hands, would not let her fall down, and keep her to safety, take her to safety. Imagine that you are the healthcare provider or a resident, and this is your patient. And your patient expects that you are going to hold their hands, take them to a position of safety, would not let them fall down, and they will come out from this hospital care happy and secure. Now look at this little girl, blindfolded, not seeing what is to be done by the person on the other side, that master trapeze artist. Now that is the kind of faith which is known as blind faith. And this is the kind of faith which the patients, they have in you. They think that when they are in the hospitals, they are going to be taken care of. You are going to hold their hands, would not let them fall down, not let them become a victim of that disease, and ultimately carry them to this safety. So that is the kind of trust which these patients, they have on us, on the residents, on the healthcare professionals. So since I'm a surgeon, let me take you to another level. That is the slogan which the surgeons, they raise. Trust me, I'm your surgeon. And the people, they have their trust. Tell me, what is trust? Is it something related to caste, culture, creed, profession, rang, nasl, akal, shakal? Iske saath iska taluk? What has this team done to gain the trust of their patients? This team has shown the patients that they are safe and they will provide you with the top quality care. And how this team has done it, I'm not talking about this particular team, because there are certain teams which are more trusted and there are certain teams which are not that much trusted. And the patients, they don't know. So how do these patients, they develop their trust on these teams? Because these teams have effectively divided their teams into smaller teams who are looking at each particular aspect of the care of that patient. You know, every surgeon does not possess all the capabilities. He might be a top quality, skillful master. He can have a great attitude. He can have a great academic knowledge. Some are very good at communication skills. Some are very good at conflict resolution, but every surgeon does not possess all these qualities, or a physician or a healthcare provider. So these teams have been divided. They divide themselves into smaller groups, and they look at in each and every aspect of the care of the patient when the patient comes to the hospital. And remember, this care starts right from getting an appointment, coming to the OPD, sitting environment, how the patient is checked, what are the protocols, how the patient is going to get an indoor admission, how the investigations are to be done, and how the treatment is to be initiated, and how the surgery is going to be done, and how the patient is going to be discharged, and even the billing aspect as well. So there are 10 aspects which are looked after, but smaller components of this team. So that is what they're doing. So that is what we want to inculcate in the residency programs. So if you think the residents who are sitting back there, if you think that are we worthy of this kind of trust from the patients, then I think that we can proceed on with this lecture. Are we? I don't have a doodle poll, but can you raise your hands? Do you think that we should be worthy of this trust from the patients? I see one hand, 2, 3, 4. Not? Yes? Some more, please? Okay, that serves my purpose. So I think that we should be worthy of this kind of trust from our residents, that when the patients from the patients, that when these patients they come to the hospital, we should be able to provide them with a safe, effective, and a top quality care. And this takes me to the question that what is quality improvement and safety? This has been discussed very brilliantly by Professor Khalid Haq. But I must tell you that this is just a data-based activity specifically designed to achieve a change which is immediate. We're not talking about great researches because they will take time to be implemented. We want this change to happen quickly. So we need to identify and focus on a particular aspect of the patient care and see what change is required. We need to go and see the insight of the systems and see that what needs to be corrected, and that has to be corrected there and then. And this must involve not only the patients, but the healthcare providers, the institutions, and the program directors. Everybody has to be involved in this. So why quality improvement and safety projects are necessary for residency programs? Why they have to be inbuilt in the residency programs? Why is it so important? Simply because, they affect the quality, the safety, and the efficiency with which the patients are treated in an institution, in a hospital. The patients demand that their quality, the demand that the care which is being provided should be of top quality, it should be safe, and it should be efficient. And not only the patients, but your health regulatory authorities, your departments, your Punjab Healthcare Commission, your Pakistan Medical Commission, they demand that the care for this patient should be safe, efficient, and of top quality. Aur jis tarah bhi aapne ye haath khade hue dekhe, the residents themselves, they have got a great desire to be participating in processes where they can ensure that the care which is provided to the patient is top quality and it is cost effective, because this is important for the future practices. They want to know this. How is it done? और ये तो आपने कई दफा सुन लिया कि what makes a good quality improvement program. ये अभी 2 दफा हम इस पे बात कर चुके हैं, and I don't think that this needs more elaboration. So how are we going to implement? Let me ask 2 questions from you. How many of you have ever participated in a safety improvement program for a patient? Or that matter, a quality improvement program for the patients which you've seen? 1, 2, 3, 4 senior people, and the residents? No hands? All right. Now this is simply because the reason I don't believe that all the residents who are sitting over here, they've never come across a moment where they could think that yes, this patient could have been provided a better care. But they don't come up with these questions. Why? One, that maybe they are not bold enough. And second, that probably they have never been encouraged enough. They've not been encouraged to ask these questions. Because if they do it, that is the time, that is the learning moment where you can provide a good amount of care and make a difference in the care of that patient. And when you make this difference, make sure that it is shared and is published. I'm going to show you an example, but however small this difference is, please share and publish it. So the program requirements are at 3 levels: the resident level, the program director, जिसको हम College of Physicians and Surgeons में supervisor कहते हैं, and the institution level. In तीनों levels पे, this program has a requirement to be implemented. And how it is going to be done? First, the resident level. The residents are expected to systematically analyze the care of the patients and identify the pitfalls. It is you, the population, the residents, who are going to identify the pitfalls. कि कहाँ पे care में कमी आ रही है. And they should be using clinical databases and see that quality improvement can be done. They should believe that if they're going to think about a change, this change can be done. And these changes are very small, like giving a proper regular appointment, caring for this patient, making a good discharge slip. So we'll talk about that. And then implement these changes with the goal of care improvement. It should be improving the care of the patient. And the program must be committed to and responsible for promoting patient safety. That is of paramount importance. And what has to be done by the program directors? Many of the program directors are sitting right in the front. They have to ensure that these quality improvement and the safety programs are integrated not only in their units, but with different departments as well. And they have to ensure that there is monitoring of the patient care, and there are definite performance improvement indicators in the patient care. That is their job to do. If not, they are not going to take an interest, it is not going to be done. And naturally, the institution has a responsibility as well. The program should emphasize on the responsibility of the sponsoring institution for the quality and safety of the environment for learning and patient care. And they should be able to develop a close partnership between the residency leadership in the College of Physicians and Surgeons, Pakistan, because I'm talking in context of Pakistan, and the institutional leadership, which we're always trying to do that. And we should ensure, the institution should ensure that the morbidity and the mortality conferences are done and the residents, they participate in that. This has been discussed. What should be the plan? The plan is to plan, do, study, and act. And the plan is very simple. Professor Khalid elaborated upon the plan that we have to aim what is our project. We have to come up with improvement ideas. We have to determine what change do we want to bring. We should collect the data. We should measure the impact. We should always measure the impact, because Professor Khalid said that you cannot manage what you cannot measure. And that is very important to understand. So you should be able to measure. Only then you will be able to manage and record your progress and see what are your predictions and expectations. And there might be certain consequences for that. That should always be noted. And then don't wait. You think that it is doable and achievable and can be recorded, it can be measured, please go ahead and do it there and then. Carry out the change and record. And use run charts. इसके भी बहुत सारे examples में दिखाएं कि run charts दिए जाते हैं. And documents the problems and unexpected observations, and always analyze your data. It's not difficult to do. And do a study. Do a complete analysis of the data and record your results. Compare your data and your predictions, that पहले क्या था और अब क्या होगा बाद में, and what did you learn. And then finally, you have to act. What modifications are needed? Are you ready to make that change? Or are you ready to make another change as well? And this all has been depicted beautifully in the previous 2 presentations in the form of this chart, which was done by Langley and Moyne. And it beautifully explains the plan, do, study, and act. That what will happen if we try to do something which is different? Okay, let's try it. And did it work? And what's next? I can remember one of my residents, Dr. Anam, telling me that, sir, patients को appointments में बड़ी problem आती है. They miss their appointments they come late in their appointments, what should be done? Maine kaha, aap socho, what should be done? She said we should give a mobile to one of our receptionists, and the receptionist should actually contact these patients 48 hours earlier and 24 hours earlier and send a text message as well. And we'll see the difference. And the difference was seen in within 15 days. 90% of the patients were not late for their appointments, and only 5% were dropouts. So we took it to the next level, that is appointment for the scheduled surgeries. So a very small little change that helped us and that helped our patients as well. And the patients were really happy. Koi contact hota hai, koi batata hai, koi hame welcome karta hai, koi hame introduce karta hai. Okay, I'm going to show you a short video. And this video is about a small quality improvement change which was brought at Services Hospital, conducted by Mr. Matthew Clayton, who came down all the way for UK. And this was done for the British Medical Journal, who are running these quality improvement projects, and it was published over there. Can you play the video, please?
On average, it actually takes 17 years for a piece of research to get into clinical practice.
We have the video.
But that's the difference between the kind of research I was just talking about and a quality improvement report. Let me take you to Lahore, to a hospital in Pakistan. Here, a group of junior doctors led by a doctor called Matthew Clayton did some very brilliant work to improve the experience of patients.
A huge problem is that the outpatient clinics, patients come back to maybe 6 months, 3 months after they've been discharged from hospital. They have sometimes just not taken the drugs at all. Sometimes they took them all in the first week. Sometimes they've overdosed on them. And this is simply because they do not understand the handwritten discharge prescription they are given. We wanted to make an intervention. We designed a pictorial-based discharge prescription chart. So instead of sort of handwriting the name of the drug with a lot of sort of medical acronyms, we made it much simpler. We had a sort of picture of a sun rising over the mountains to represent morning, a sun above the mountains to represent midday. We got the pharmacist to start writing number 1 or number 2 or number 3 to correspond with our discharge medication sheet on each of the boxes of drugs they gave to the patients. The pharmacists understood this concept. They were very happy to sort of engage with the whole project. And all of a sudden, illiterate patients had a box. They could read the number on it, and then they could refer to the chart, and they could see just where the X's had been put to mark the time of day they should take it and how many days they should be taking it for. And by the time we left, within 9 days from start to finish, this discharge pro forma was being used on the medical wards in this large teaching hospital in Pakistan. And since then, I think it's been extended to the sort of surgical wards and other wards since as well.
This project was published in BMJ Quality Improvement Reports, and it showed that there was a 20% increase in patients' understanding of their prescriptions. This was a fantastic report, and what's really exciting about it is that later on, a hospital in Toronto did a very similar project after being inspired by reading this project. And that's what we want to try and encourage people to very quickly publish their work and share it so that other people around the world can emulate the ideas that are generated from projects.
Okay, thank you for watching this video. And
on average, it actually takes 7.
Next slide, please. And let's see, since I look after the National Residency Program, let's see what has the National Residency Program done so far. We have got the structured residency program, which is competency outcome based, the ELOG system of the CPSP, the acquisition and implementation of the skills program like basic surgical skills, ATLS, ACLS, BLS, PALS, also FLS and FES. And then we had a safe laparoscopic ostectomy with the collaboration of the Society of Surgeons. What I'm just showing you is the structural visual curriculum display charts, which have been made specifically patented by the College of Physicians and Surgeons of Pakistan. This gives the residents the outline of their competencies and the mapping that how these competencies are going to be achieved. So this is available with every department all over Pakistan, where the competencies are charted up and how these competencies are going to be achieved, the pathways are written. Then we have the CPSPE portal through which we actually measure and record these competencies. And all the supervisors who are sitting over here, they understand and know how to utilize this CPSPE portal. And we thought that skills have to be imparted on the residents and the supervisors. And we targeted 5 life-saving skills, starting right from the childhood, the pediatric advanced life support, advanced trauma life support, advanced cardiac life support, the basic life support, the advanced life support in obstetrics and pediatrics, obstetrics. So we targeted these 5 very important areas of human life. And we started this skills program all over Pakistan, and we run it every month, every year, day in and out since year 2007, very successfully. And recently, the most recent intervention, a small quality improvement project which has been done, there were reports coming up that there are many common bile duct injuries which we are receiving at the teaching hospitals. So we thought that a safe laparoscopic cholecystectomy initiative should be started, just in the lines of the American College of Surgeons. So with the help of the Society of Surgeons Lahore, Professor Waris Farooqa is the vice president and Professor Farooq Afzal is the president. With their help, and Lahore General Hospital and Research Institute of Medical Sciences, we started a mini fellowship. We laid down the program, we devised the curriculum, we advertised, we collected the CVs, we conducted the interviews, we had a seminar, and then we actually had the training. So this was the advertisement. And to our surprise, when we advertised, applications started pouring in from all over Pakistan, from KPK, from Punjab, from Sindh, from Balochistan. And so to our surprise, there were 4 applications from abroad as well: Oman, Egypt, Afghanistan, and Saudi Arabia. So the trainees and the residents and the supervisors, they really felt that this was the need of the hour. So this was a great intervention, actually. We were also ourselves amazed at the kind of applications which we received. So we had to shortlist them. We had a committee. And then we had an inauguration seminar. And we actually first told them that what are the flaws, and then proposed the changes, how it's to be done, had them pre-tested as well, and then conducted the skills courses with them. And this was the improvement felt by the candidates under 5 areas. And this improvement was felt by their peers as well. And we asked them that what else do you think that could be done? And we were so encouraged by this that before we actually got the actual results, we announced the hernia workshop. And before the results came in, we were so excited, we conducted this hernia program as well. So we finished that hernia program about, how to do a safe hernia about 15 days back. So that is the kind of interventions which we require, small interventions just to help out. I'm a surgeon, so I was doing interventions at the college level, at the institution level, at the society level in surgeries. But that is what is expected out of all the residents, all the programs, and all the specialties which are, and I'm sure that they must be doing it. So to summarize, initiating and participating in quality improvement and safety programs often allow the residency programs to achieve incremental and measurable changes which make a real difference to the patient's experience in the hospital. So think differently, use simple systematic approaches, organize, make a change, and evaluate it to see if this has worked, and always document and share it. It will be published, it will be shared all across the world, I promise you that. The ultimate outcome would be the safety and security of the patient. And the quality improvement project should be a core competence in the medical education and postgraduate training programs, as this will ensure patient safety. So before I leave, I must thank Professor Khatija Irfan and Professor Tahreem and Professor Matthew Clayton for helping me in this presentation. They were there to help me out. And I leave you with this picture, this blind faith. So make every possible little step to gain the trust of this patient in your residency programs, so that the patient feels that he or she is safe and there's a definite top quality care which has been provided to the patient. Thank you very much. I'm here for any questions. So I think Khatija has a question.
Thank you for a very brilliant presentation. It's sort of like many aspects of it really were very close to my heart. And I feel that this is what our responsibility is, that we have to be like that trapeze artist and we have to hold the patients in our hands. My question,
so remember this picture forever, this trapeze artist and the girl jumping in blind faith.
Beautiful, beautiful. So my question is that do we have a plan to, because when you said in your last recommendation was that it should be a core competence in residency programs, but we all know that our culture as a society is that we don't do things unless we have to do them. Should it never works for us, must works for us. So do we have a plan how we can convert this should into a must, so that we actually, because for the last 20 years or so, since the Bristol Inquiry in the UK, clinical audits have been a compulsory and mandatory part, and one clinical audit to be done annually is a mandatory part of training in the UK. And in the US also, since 2011, I believe, they have had in all their residency programs, it is now a requirement, which is why now they're having these big quality conferences all around the US and the UK, is because these are like required and a must for them. And with that must, they have improved. So can we make that should to a must?
Yes, I think that the college runs 14 different workshops, not only in medical education, but in various skills workshop. And I think that as the director of the National Residency Program, I've got this very clear concept that this quality improvement and safety workshops, they have to be a part of the curriculum of the college now. So after this workshop, maybe I can sit down with you and Irfan and the Vice Chancellors of Lahore and Professor Waris and where is Alia? I think that we need for a few people who can actually come and join us. We have already planned a workshop. We just need a word of wisdom. Professor Sirajul Haq, who is a lead medical educator who looks after the Department of Medical Education, he has almost formulated a workshop for that. And I think that it has to be a part of our residency programs. And this quality improvement safety workshops, maybe 1 day, 2 day, 3 day, I'll be happy to participate in that. We'll have a faculty and we'll do that. Sure, thank you.
Professor.
A question from Professor.
Professor Ayyaz, you have an excellent and comprehensive presentation. But my question is, you said we are going to have 3-level implementation for patient safety, right? At the residency program, supervisors, and institutions. Have you implemented in this curriculum or not?
No, not yet. ये जो है आपने जो structured visual curriculum display charts आपने देखे, इसके अंदर the competencies which a resident should have, they have been labeled, and the pathway how to acquire these competencies, that has also been labeled and clearly determined. Now it is really up to the supervisors to make sure that these competencies are acquired and these competencies are, completed before they sign them off for their final fellowship examinations. So really the supervisors have to be alert about this, and they have to be participating in this. Like few of my residents are sitting in this audience who know that I would not sign them off from the residency program till they assure that they have done these competencies. But there are plenty of professors who would just sign ke bas 4 saal pure ho gaye, kar den. But that has to be stopped. We have to ensure that this competency has been achieved. और जो competency आपकी निगरानी में achieve की गई होगी, that will be a safe competency. I assure you that. But sometimes we just sign them off, and I don't think that is right. Because GMC में it has been, and which is PMC is also going to say, it is not going to be the tenure of your residency program. It is the number of procedures which you have to document. GMC says that if you have to do 300 orthopedic procedures and your training program is 5 years, if you've not done these 300 procedures in 5 years, do it in 6 years, 7 years, 8 years, only then you'll be eligible for that FRCS orthopedic examination. So that is what should be done.
Professor Irfan.
Thank you very much for this very nice presentation. I'm very happy to learn that at least it will be incorporated in the residency program. The examples you showed in your presentation of improvement were mostly of the college. And that was my query in my mind, that what were the actual steps which were done for the PG students, and you have answered it. Inshallah, it will be incorporated. My only question is, what happened next to this girl?
This girl is safe and sound. She would not jump till she has this faith. So that is what I want, that our patients should have this faith in us, that when they come into the hospitals, they would be looked after. And that can only be achieved if this quality improvement and safety projects are inculcated into our residency programs. So maybe we can have the next speaker now, or I'm supposed to, Gigi, please.
A last question.
Assalamu alaikum. I'm Dr. Gulshad, head of endocrinology, Berry Hospital, and I worked abroad before also.
Sir, I cannot hear you. Can you just come closer to the mic, please?
I'm
Yes.
I'm Dr. Gulshad. I'm head of endocrinology department, Berry International Hospital, Lahore. I worked abroad before in UK and UAE and Saudi Arabia. I mean, it's very just blind faith. I'm just giving one example. I think recently I saw in my clinic one patient, and she was told that she will be changed from girl to boy because I do endocrine clinic. And when she came to me, I saw her operations done, surgeries done. And when I examined, I felt that she was genetically female. I did chromosomal analysis, and that was, it turned out to be a female karyotyping. And plus 17 hydroxyprogression, so late onset CH-like things, you know. So she was having periods problem, you know. So I think the doctor's training and more of the ethics and other things, the surgeon did the surgery and they took the money. And you know, these things, and this I could not dare to publish this kind of report, you know, because the patient who is from a village and he's an innocent and he was thinking that I have got all the girls and this will become a boy. You know? So I think these kind of the training and ethics, it has to be learned to teach to the juniors also.
Yes, that's very important. That is why these need to be incorporated into the residency programs so that they know that this has to be done.
Yeah,
I totally agree with you.
The other thing is, I saw one case. Operated in a government hospital, and total thyroidectomy was done, and they removed for benign multinodal goiter. And I don't know, because she came later on to me, and she developed, you know, like post-surgical hypoparathyroidism also, which was not appropriately treated. So I think these kind of things also, the ethics is that the surgeon or the other specialty people, they should refer to the other specialty before consultation, you know,
yes,
before taking a final decision, so that appropriate management is done. So this also needs to be taught to the juniors, you know, about these things. Another thing, one of my very close relative who is having dialysis in a grade A hospital, and he developed hepatitis C during dialysis there. And I spoke to the head of pathology. He said that the screening we do, it will save you about 80, 85%, 15% chances are still there. You get the infection, you know. So, but the people in general, they don't know that there are still 15% chances. They are paying the money for screening and everything. The poor guy is suffering, you know, now. So I think these things, I agree, this was a very good, I appreciate that to start at least from something, this quality improvement thing, you know, and I appreciate your efforts also. But I think there are many more things to be done also in this measure. Yeah. That's my comments actually.
Thank you.
Thank you very much, sir. Thank you very much.